So just to introduce myself, I'm Elise Hausberg. I'm a maternal fetal medicine faculty here at the University of Pittsburgh. And I have the distinct honor of moderating this fantastic panel. So I'm going to give our speakers a chance to introduce themselves. And then we're happy to take questions either through the chat or for those who are here in person by coming up to the microphone. Do you want to get started?
Sure. My name's Lou Muglia. I'm president and CEO of the Burroughs Wellcome Fund. And at the Burroughs Wellcome Fund, we're extremely interested in supporting understanding the reproductive sciences broadly. Long-standing interest there. Before that, I was a pediatric endocrinologist and director of human genetics. And through my career, my real passion has been trying to understand the mechanisms that control birth timing. If I could have the first slide, please. And I only have 2 slides. So this has been the big question for me throughout my 30 years working in the laboratory. What determines the timing for birth? For every species, we know that there is an optimal time, a typical time that emerges from the intrauterine environment. For humans, that's 266 days after conception. If you're a mouse, it's 19 days. But for no species do we know how it knows when it's there. And to me, this is just one of the most fascinating biologic questions we have to answer. But we know it's of extreme medical importance as well, because preterm birth, as we've heard, and all of you know, is the major killer of infants and children under 5 years old. And we know that that's influenced by a variety of causes. Genetics, as I've tried to approach, though I've used that not because I think it's the main driving force, but it's an unbiased key to get into the system. But we know inflammation and infection, as we heard from Dr. Romero, nutrition, maternal health behaviors, socioeconomic influences, including racism and its epigenetic and transgenerational consequences. So we need to address all of these things for every woman, as we've heard today, to really optimize pregnancy outcomes. Next slide, please. So what my vision for the future is, and this is not too different than what we've heard, I think, from Dr. Hood's talk this morning, from Dr. Romero, from many, is to really use women and human infants as our model system of choice to understand human pregnancy and impact appropriately. I think we can routinely capture pregnancy outcomes for both mothers and offsprings in electronic medical records, which really isn't done very well right now in both high and low resource settings. Integration of our genomes and becoming part of our medical record, which we've talked about now for many years, but really hasn't become a reality. But I want to emphasize precision medicine in pregnancy is more than just genomics and genetics. We really need to capture social determinants. There are fantastic dashboards to do this that we don't incorporate now, health behaviors, nutrition, environmental exposures, so that we really can develop a preventive strategy for adverse pregnancy outcomes for every mom. And you know, one thing they asked us to think about some bold kind of statements. And you know, what I was impressed with the talks today was the magnitude of the technology that can be brought to bear on the system. But it reminded me of a quote by Steve Jobs. Technology alone is not enough. Technology marries with the arts and the humanities is what makes our hearts sing. And I think as part of what we're doing in pregnancy especially, we have to remember our humanity, about what it means to be human, around human happiness, around purpose, and around connection with community and environment, as we've heard about in some of our advocacy discussions yesterday. So without bringing that into the technology, I think we're never going to quite have the outcomes we want.
That's great. Thank you so much for that intro. Dr.
Well, Lou, I think you've pretty much said it all from my perspective. You know, you've heard me this morning earlier. I'm a clinician, and I tell my patients that I only do 2 things. I identify risk, and I try and minimize the impact of that risk. So those are the only 2 things I do on a daily basis. When they ask me, what do I do? When my kids ask me, what do you do, Mom? I do 2 things. How can we do that on a larger scale is something that I've thought about, and Lou has mentioned that so much. And when you think about risk in pregnancy and risk for lifelong health, it's what do we bring into? It's the lived environment before pregnancy, the clinical risk before pregnancy, the lived environment, the clinical risk during pregnancy, the genomic risk, and then what happens after pregnancy and how does that affect the lifespan. So in thinking about, what I would like to do would be collecting all of those, like you've mentioned, Lou, is collecting ideally and doing a large multidisciplinary study in many areas of the country before pregnancy, during pregnancy, and after pregnancy, and thinking about those long term. And then with the technology that you've mentioned, Lou, and we heard about this morning, we could provide much more precise answers about risk and how we might mitigate those. And Jolie and I were talking at the break and saying you wouldn't need to actually test all of those at once, but you could collect everything so you could go back and test it later. So as Yoel made me think about what should we do, what would be ideal, that's what I came up with in terms of the lifespan and how we could make patients healthier. I think one of the things that will be very difficult is the patient participation and the provider participation, I think on a more secondary level, but patient participation. And I think about that specifically with lifestyle and weight reduction. I just see that as being a pretty monumental task. So that's what I've been thinking about, and thank you very much for having me here today.
Thanks for joining us.
Thanks. Janet Kadoff. I'm an associate professor here at the University of Pittsburgh in the OBGYN department at Magee-Womens Research Institute. I'm an epidemiologist, and I study sort of causes of adverse pregnancy outcomes and what they reveal about a woman's risk for later life disease like heart disease. And so I bring a women's health lens to pregnancy health for a couple of reasons. In part because I think it can actually, what happens after pregnancy may give us actually some new etiologic clues about what might be happening during pregnancy. And also it's a really unique time that women are young and healthy and available to us. So there is both opportunities and missed opportunities. When I thought about what have we done and what might we do more of, three things come to mind. And it was mentioned, actually, Mary, you mentioned it this morning. We have to really pay much more exquisite attention to disparities. And what that really requires is not only collecting data. When I started in my work, was the beginning of the time when we were first collecting cardiovascular disease data by sex. Because until we did that, we actually didn't know what was different. And I would suggest that the same is true around race, ethnicity, and disparities. We've begun to do some of that work, and I will tell you that it requires great humility and much more listening. We're very, very convinced about what we know and what we think the questions are. But what I have been humbled by some of our work partnering with community partners is the humility and the listening that is really required. So that's one. The other is, I'm an epidemiologist, and when I think about the breakthroughs in population health, they have really been guided by longitudinal view, not cross-sectional view. We do cross-sectional studies because they're cheap and they're convenient and they give us immediate insight, but we really have breakthroughs with a longitudinal perspective, and I would suggest that we have viewed pregnancy as a cross-sectional event and not as a longitudinal event. And I think that speaks to the before, during, and after. I am really honored to be part of a novel cohort that is, I think, a great example of NICHD and NHLBI coming together, recruiting 10,000 women in a first pregnancy. I work with many colleagues here at Columbia and Northwestern and here at Magee, and we're now following them to collect a lot of information about their subsequent pregnancies and then sort of the emergence of their own health risks. I think those are the beginnings of maybe what you're talking about, but really do require partnering with women so that we're not only collecting their data, but we're actually partnering with them, so we're listening to what they're telling us. And then the last piece, what we've spent a lot of time on, and I think echoes some of the points raised, we've been very keen on the placenta to help us begin to phenotype the pregnancy so we can maybe do some of the understanding the different pathways that lead to adverse pregnancy outcomes and maternal sequelae afterwards. I think there are new clues that we need to interrogate more comprehensively. There were many people speaking about that, but I actually think it's going to take these three aspects to make what I'm hopeful will be the next generation of breakthroughs.
Hello, everybody. It's an honor to be on this panel. I am Sarah England. I am a basic science researcher in the Department of OBGYN at Washington University in St. Louis in the School of Medicine. I would like to echo everything that everybody has said here. My work has really focused on, I was trained as an ion channel biologist, and then I realized that it always scared people, so I think I transitioned more into the maternal child health. We've really been interested in behaviors that affect women that we hope are upstream of a lot of the pathways. So recently, my work has really focused in collaboration with Eric Herzog on the role of circadian rhythms or women's daily rhythms in affecting pregnancy outcomes. We've also partnered with the people in pediatrics, investigators in pediatrics and psychiatry, looking at brain development of the children of these pregnancies and looking long term to have a maternal child health link. I guess as I've been in this department and as a basic science researcher and talking to many of my colleagues, one of the visions and discussions that we've talked quite a bit about is that we always focus on disease. And I love the discussion on wellness today, because although a lot of women have very poor pregnancy outcomes, there is a whole host of women who have healthy pregnancies, and especially for us in our population that primarily serve Black women, low socioeconomic status, is trying to separate low adversity from race, and also to figure out what goes right besides what goes wrong, and where we can actually look at this a little bit deeper to understand what constitutes a healthy pregnancy in our population. And I would love to investigate this wellness aspect more.
Great. Dr. Lockwood, do you want to?
Yeah, well, first of all, thank you very much for the invitation. I'm really sorry not to be there. Ironically, I figured we were in the midst of the worst aspect of the COVID-19 pandemic in Florida when I said, well, I can't possibly come to Pittsburgh. And now, of course, we have the lowest numbers of cases since the start of the pandemic here, and it's starting to pick up again in the north. So you just can't predict much. Secondly, I realized that I have like a giant 1984 Orwellian picture over everybody's head, so I apologize for that. So in my role, I have a complex job, I guess. I'm Dean of the Medical School, Senior Vice President for what's called USF Health, which is essentially like a health provost. And the other health science colleges report to me. And then we also have a very large multi-specialty practice. And every day I have to get up and think about our three critical mission areas of education, and it's not just educating our medical students, but everything from public health folks to athletic trainers and everybody in between. Research, obviously, and then clinical care. And I would say that the most daunting part of that job is the ability to adjust for the sheer acceleration of knowledge across all three areas. And I use the example of the aggregate increase in medical knowledge when I have been talking to our medical educators about continuing to adapt and modify our medical school curriculum. So when I graduated from medical school in the Pleistocene era of medicine, 1981, medical knowledge doubled about every 20 years. So you could pretty much memorize Williams and Harrison's and Savaston's textbooks and be pretty up to date. It was estimated, as we were starting to build our new medical school building back in 2014, that by 2020, medical knowledge would double every 73 days. And the AAMC is now suggesting that may be every month. So how can you possibly keep up with that? Whether you're talking about educating medical students, or being a medical student trying to be educated, or training residents or fellows, or keeping up with your research, or just taking care of patients. It's an incredibly daunting challenge. And it's up there, I think, with climate change and globalization of our economy in terms of the real true challenges facing humanity. Tom Friedman wrote a book a few years ago where he suggested that the pace of knowledge across the entire society had already exceeded our brain's ability to keep up with it. And that was a few years ago. So I think the answer is that we have to echo some of the themes that you've already heard this morning. We have to better marshal AI and use it as an intelligent assistant, as Tom Friedman might say, or intelligent assistant, and to curate information and to apply it to the problem at the kind of point of care and point of need. I think secondly, we have to work in teams. And we have to be open to lots of disruptive ideas without going mad. And so I give this example of kind of how that might work. So early on when I got here, I had to pick some general themes for our research efforts. And they in part reflected, I live in Florida, they in part reflected the healthcare needs of Florida and therefore trying to meet those both clinical perspective and for our students. And they were clearly heart disease, which is the leading cause of death in Florida. And with that, I would add pulmonary and disease and stroke, Alzheimer's, and neurodegenerative diseases. I'll leave that to your imagination in Florida. And infectious disease. I kind of guessed right on that one. My initial thinking was that Florida was sort of a biopsy needle sticking into the South America and Central America. So that one I just got lucky with. But what I wanted to do was to ensure that there was a lot of communications and interactions amongst all the research groups, and not just in those three areas. And one of the things that I try to do is go to as many research meetings as I could. And at one of those research meetings, I was listening to a group of neuroscientists talking about Alzheimer's disease, and they mentioned a protein called FKB251. It seemed interesting, and they suggested that it was important in epigenetic changes in the genome of neurons, and that it acted as a chaperone protein, might be involved in tau and amyloid metabolism. And then they happened to mention that, yeah, and it also bound to glucocorticoid receptors and to progesterone receptors. And my ears perked up, and they had a transgenic mouse, and I asked them, do you know anything about the ontology of that mouse? Did they have prolonged gestations? Or because I knew from their presentation that it impeded progesterone receptor activity. And make a long story short, no, they had done no reproductive phenotyping at all, and it did prolong gestation. It turns out to be a fascinating molecule that has been source of really almost all my limited lab time, but it works in ways that I could probably spend several hours describing, and that's not important. I think what is important is that when you keep an open mind, when you are allowing yourself to be exposed to a lot of information, then trying to curate it, good things will happen. And I think that I guess my theme is that we are in an age awash in information and data. Some of it's useful, some of it's noise. And the great challenge for educators and researchers and clinicians is to sort through that noise and figure out what really is important and apply it to the particular problem that you're working on, and to appreciate that we are going to continue to have this period of rapid acceleration in our cumulative knowledge, and the tasks are going to become more and more difficult. And we're going to, I think this is one of the three great challenges facing civilization.
Thanks. And thank you all for those wonderful points and introductions. I want to be sure we have some time for audience questions, and to kind of, we brought up a lot of points here today that I think I'd like to kind of try to work on tying together. I think some of the big themes that have come up have been, working together as a team for sure, and that we need to not be sort of operating in silos in medicine, right? The other points that have been raised are sort of thinking about pregnancy more as kind of a continuum across the lifespan, and thinking about how we can use some of this big data to actually to apply to our work. Maybe we'll take a minute to kind of go to the audience for some questions. Dr. Sadowski, it looks like.
Yeah, thank you very much. And Charlie, thank you for joining us from Florida. I know we have very limited time, but one thing that came out of the sessions that presented by Roberto Romero and David Haig, and also illustrated by the panel we have, the 6 of you, is really 2 ways to think, to look at the current OBGYN practice and diseases. 3 of you on stage, Charlie, Sarah, and Lou, in your past life, have done very mechanistic molecular studies addressing key pathways that lead to diseases. Now, all of you have now shifted to much broader view, with Mary applying it to patient care and the challenges we have right now. The question is, are OBGYN physicians right now equipped to deal with the challenges you just presented? Should we change our fellowship training structure? Do we need to change how we approach residency, even potentially medical school, to deal with tomorrow's challenges as you all presented?
It's a great question. Any takers?
It seems like for Charlie.
I think Charlie should go first, and then I'll go.
Well, thank you for that impossible question. But, I would say that the same challenges apply to every field of medicine. And again, it gets to the pace of knowledge accretion, which just keeps accelerating, and the complexity of the challenges that we face in providing care. And so you could say, if you think OBGYN is in a confused state, look at general surgery and their inability to differentiate between their different specialties and subspecialties, fellowships and residency programs, et cetera. It actually makes me feel comfortable that we are one of the better organized and more logical fields. But I am constantly concerned with the ability of all fields to adjust to this new era, and also to adjust to a different mindset of the students and the trainees, and different desire for a more balanced life. All those things, I think, add to the complexity of the problem. I think that we've talked in OBGYN about should we be a 5-year residency program? Should we blend into fellowships? What should those fellowships look like? Should there be the equivalent of the family medicine component of a specialist? I know that probably everybody on the panel has their own views on that. But all I'll state is that we are not alone in this period of self-reflection and maybe even turmoil about how we optimally train our residents and fellows. And frankly, it starts with first year of medical school and the whole nature of medical school curricula, and how do you really make a choice about a specialty, and do we need a 4-year curriculum? Do we need more flexibility within the medical school curriculum? We're not given a lot of flexibility by the LCME, so it actually starts even earlier than that goal. You know, I don't know that any of us have a great answer to that question.
I would just add to that, Charlie, by saying I do agree with you, Yoel. They're not equipped, and one area that I think subspecialization has done enormous for our field. You know, we've better minimally invasive surgeons, we have GYN cancer, we have infertility, we have MFM. I think where subspecialists have, where the subspecialties have kind of failed us is in the general management of patients. And when I was training way back with Charlie, the gynecologist was the quarterback for women's health. They've really lost that role right now. At least in New York they have, but no one has filled that gap in New York. So that's what I'm doing more in New York now, is having gynecologists be the primary health care drivers for women as they age, and we have an aging program as well. So I think we need to think about how we're going to train our general obstetrician gynecologists, and perhaps add another year to training the OBGYN specialist, because they're not going to do surgery. At least in New York, they're not going to do surgery. They're going to go to minimally invasive surgeons or GYN cancers. So I think we've really got to figure out the role of the OBGYN generalist. I know that all politics are local, and it's different in New York than it is in some rural communities, and in many rural communities, GYN physicians are doing surgery, but that's becoming rare as they're just not getting enough volume as they train. So I feel the urgency is not in reevaluating the role of the subspecialist, but in reevaluating the role of the general obstetrician gynecologist.
Yeah. Great. I think we can take one more question.
Before we eat. Tracy Bale from the University of Maryland. So I applaud the incredible depth of this panel. It's wonderful to hear and to be amongst this great conversation. One of the things in Janet's discussion and bringing in the lifespan, which is fabulous to think about not just the state of the pregnancy, but for women's health and for child health, what happens after. What I haven't heard as much about is the lifespan that includes the before. And it's mentioned a little bit, sort of, but I think mechanistically we're missing a little bit here in this discussion. You know, just take the Kaiser Permanente adversity across the lifespan, especially preconception, is one of the strongest predictors for women for negative health outcomes. And so I think if we're thinking mechanistically of those contributions, that in the state of pregnancy, that those are in large part responses to all of that adversity that has happened before. And can we define better questions to ask, and ensuring that we're addressing low-resourced populations that are not all just the average, which we all know the Kaiser Permanente study sort of initially did. And then how does that inform what we might be looking for at conception, in pregnancy, and after? That might lead us down the road of biomarkers, or ways in which we can say, wow, this is risk biologically. How do we then intervene? So I don't know, Janet, if you want to.
Yeah, no, it's a great question, Tracy, and I completely agree. I mean, I think a true lifespan approach, we know, and from the data that you mentioned, I'm just suggesting, where do we start? And I love those conversations. So I think we need to be partnering with adolescent medicine, with pediatrics, you know, not just sort of, and of course this isn't what happens, but not just sort of a pass off of, you know, newborn to pediatrics, but actually partnering with pediatrics. And I think that might be We talked a little bit about teams. I think this is a natural alliance. And I just have to mention as well just the profound challenges of disconnects in care. You know, not only kinds of care, but access to care, insurance coverage, and this sort of labyrinth of a system that individuals have to navigate to just get basic care, let alone groundbreaking care. So I agree with you. I love that we're having these conversations, that we really need to be talking about preconception health. And in a country where we still have half of pregnancies that are unplanned, you know, we have a lot of work to do in terms of understanding women's needs, women's health, in order to optimize care before she even comes to us. I say to my kids sometimes, you know, we really don't need a lot of advanced education to know that the healthier a woman enters pregnancy, the better she's going to do. Like, our mothers kind of told us that. So I think our task is how do we change the science and the data and the systems to be able to do more of that. Absolutely. I would just throw one point, is that a postpartum period for one pregnancy could well become the preconception period of the next. So there's like easy places to start. There's hard things we need to do, and there are actually easier things we ought to be doing today.
Yeah. And I think for those of us on the screen or on stage who are obstetricians, you know, by background, we always prefer to see women preconception, right? Like, there's so much that we can do when we can actually take a proactive approach to health and pregnancy. So, yeah, I'm getting the signal that I think it may be time for lunch. So I appreciate everybody so much for joining us for this panel, for the wonderful questions and discussion that we've had so far this morning, and looking forward to a great afternoon. Thank you. Thanks.